Good afternoon, everyone. Happy New Year. My name is Cinda Rushton, and I'm part of the core faculty in the Berman Institute. And it's really a delight to welcome you to our seminar series and to introduce our colleague who will be speaking today, Dr. Yoram Unguru, more affectionately known as Dr. Yo. And we are really delighted for him to have an opportunity to share some important work that he's been doing that is directly a reflection of his clinical work in pediatric oncology. He is an attending physician and faculty member in the Division of Pediatric Hematology and Oncology at the Herman and Walter Samuelson Children's Hospital at Sinai here in Baltimore. He is also core faculty in the Berman Institute of Bioethics and has been engaged in a national conversation that he has really been leading about the issues around shortages in pediatric chemotherapy. And so today he is going to share with us his reflections on this question of unreasonable standard of care, or simply unreasonable, the clinical and ethical challenges in caring for children with cancer in an area of chemotherapy shortages. So Yoram, welcome. And also he'll tell you a little bit about his other interests in life besides bioethics.
Can you guys hear me? How about now?
Yeah, okay.
I'm told I don't need a microphone, but I like to walk around a little bit, so I'll do Phil Donahue. No? Huh.
It sounds like it's really close.
Really close?
There you
That
go.
better? Okay, really close. Okay, thank you all for coming. Thank you for that kind introduction, Cinda. In the time that I have, I'm going to cover three broad areas. I'll begin with an overview of pediatric oncology for those of you who may not be familiar with it, to kind of set the stage. And then I'll segue into some of the reasons for the chemotherapy shortage issues and the reasons that they are happening and what they present problems for clinicians and institutions. And then I'll segue into what colleagues and I, including colleagues here at Hopkins, have been working on to address some of these shortages. So here are today's objectives. And I'm a pediatric oncologist, which means that I don't have any disclosures. And you may see me starting to get hot. I grew up in Israel, I have a lot of fur, I'm always hot. So if I take off my jacket, I'll limit it at that. So back in the 1960s, kids who were diagnosed with cancer really didn't stand much of a chance of defeating the disease. But as you can see here, at least when it comes to some of the more common childhood cancers, things like ALL, Wilms tumor lymphomas, the overwhelming majority of these kids do survive, and this is largely the result of cooperative group clinical trials. But before we get too self-congratulatory, while we made some advances in curing some of the more difficult diseases like AML and high-risk neuroblastoma, you can see that still about half of these kids don't live more than 5 years. And as my esteemed colleague, Dr. Cohen over there can tell you, when it comes to diseases like brainstem gliomas, we really are struggling in that regard. But let's talk about what's common. Acute lymphoblastic leukemia, or ALL. That accounts for a quarter, almost, of all new cancer diagnoses in children. And you can see that each successive decade, more and more children have survived, and the current survival rates are about 90% for all comers. And again, this is the result of research that we in childhood cancer partake in. Now you might imagine that these impressive cure rates of ALL and other childhood cancers are the result of new drugs and with fancy names, but that's actually not the case. So here are the drugs that are used to cure ALL. And this group has been around since the 50s, this group has been around since the 60s, and etoposide, a relative newcomer, it's been around since the 70s. Now, as we've gotten better at curing cancer, we've discovered new drugs. But it's not just about the new miracle drug, it's about better supportive care. So back in the 1950s at the National Cancer Institute, Drs. Emil Frey and Emil Freyreich realized that by transfusing platelets, they could prevent some of the life-threatening hemorrhages that kids were succumbing to. We can give antibiotics so kids don't succumb to some of the infectious complications. We can give kids with cancer growth factors so their blood counts aren't as precariously low. And just our overall ability to care for sick kids has gotten better. But as we've gotten better at curing kids, we've also gotten better, unfortunately, at causing problems. And this slide is a sober reminder of that. You can see that it's the rare kid with cancer who doesn't develop some kind of side effect. And as you can see, some of these can be pretty significant. And so really our paradigm has shifted from one of curing at all cost to maintaining excellent cure rates and minimizing some of the long-term side effects that can really affect every single organ system. So again, these are the drugs that are used to cure ALL. And these are the drugs that have been in short supply. And with that background, just to kind of give you a brief history 101 of pediatric oncology, let's talk about the chemotherapy shortages. So, if only it were this easy, right? For those of you who can't see the caricature, it's a doctor talking to his patient. He says, there's a drug shortage. I'm thinking of replacing your meds with 8 hugs a day before and after meals. But it's not this easy. So you guys are eating, and hopefully the postprandial effect hasn't gotten to you yet, but there's a short quiz. Okay, we'll see if how well you guys do. So over the past 10 years, how many of the 10 common drugs used in the treatment of ALL have temporarily been unavailable? How many of you think it's 10%? You got a show of hands, okay? It's not Chicago. Everybody votes, and you vote one time only. Do you have any takers for 1 out of 10? No. How many people think it's 2 out of 10? Nobody. We have savvy test takers here. 5 out of 10. We have some brave souls. Okay. 6 out of 10. More. They're thinking it's always deep. Okay. How many people think it's 8 out of 10? Okay. It's 8 out of 10. I'm going to Atlantic City with the 8 out of 10 group. Okay. All right. You can redeem yourself. The estimated annual costs here in the United States in dealing with the shortages, time spent trying to secure additional drugs, investigating, etc. What do you all think we spend each year in the United States dealing with these chemotherapy drug shortages and other drug shortages? How many people think it's 100 million? See, I'm a savvy test taker too, so I may have mixed these up a little bit. Nobody. 200 million? Can I get a 300 million? Okay, 400 million. Many more. 500 million. Okay, $416 million each year in the U.S. we spend on drug shortages. That's nearly $500 million. That is a lot of money. Okay? So for some of you in the room, this may not be difficult to imagine, but for everybody, I want you, for the rest of my talk, to focus on the following scenario. You're a pediatric oncologist, and you work at a busy center, not unlike the one here at Hopkins. You give kids with cancer chemotherapy. And so far, despite the growing number of shortages, you've been lucky. Your institution has had adequate drugs. But you come to clinic today, and you're told, by the end of the week, we're done with vincristine. We're out of it. And to make matters worse, the chemotherapy pharmacy director tells you the usual places she's been able to get more drugs aren't available because the primary supplier of vincristine has halted production and there's a national shortage. And for those of you who may not know, in pediatric oncology, vincristine is kind of like water. Chances are you're coming into our clinic, we'll give you vincristine. Leukemias, lymphomas, solid tumors, bone tumors, brain tumors, we use vincristine. So a vincristine shortage would have far-reaching impact on countless kids with cancer. So just keep this scenario in mind. But drug shortages aren't new. You can go back to the 1940s with the newly developed antibiotic penicillin, and that was preferentially allocated to U.S. soldiers and not civilians, and this was done without public comment. But over the past 10 years, there have been more and more drug shortages, including chemotherapeutics. And for reasons that we're going to talk about, we own this problem. This is primarily a U.S. problem. It doesn't tend to happen nearly to the same degree as it does in other countries. And I think that Michael Link captured this most appropriately. For those of you who may not know, Michael Link is a pediatric oncologist at Stanford, and he's a recent past president of the American Society of Clinical Oncology. And here's what Michael has to say. Essentially, although we've had shortages before, they've never involved as many drugs or lasted as long as they do now. So there are about 300, let me say that again, 300 drugs presently in short supply in the United States. And there's two main sources that you can go to get up-to-date info. One is the FDA, and the other is the American Society of Health Systems Pharmacists. Now, here on the left, this over here is a screenshot of the FDA's drug shortage page. And here is the ASHP's, and I apologize for the microphone. I didn't mean for this to be an eye exam. But for those of you who are up close, you'll notice that the drugs that are listed by the two aren't the same. And there's reasons for this that we'll talk about. And here you can see, probably not, this is daunorubicin, that's a chemotherapeutic. Here you can see another chemotherapeutic, doxorubicin, and this was just revised as of last week, okay? When it comes to chemotherapy though, most of the effective drugs that are in short supply belong to this class of sterile generic injectables. In fact, when you look at all drugs in the US, not just chemotherapeutics that are in short supply, up to 3/4 belong to this class of sterile generic injectables. And it's essential that we keep in mind that these chemo drugs are in short supply. They are the backbones of life-saving and proven standard regimens, not only for kids with cancer, but for adults with cancer as well. And because so many of the drugs that we depend upon in childhood cancer belong to this class of drugs, we are really feeling the pinch of these shortages. So these next slides are a courtesy of a colleague of mine, Aaron Fox, at the University of Utah Drug Information Service. And I want to thank her for sharing them with me. I pester Aaron every 3 months. You got the quarterly data? You got the quarterly data? And she, oh, yes, I'll send it to you. So here what you can see is the number of new drug shortages each year in the United States beginning in 2001. And for reasons that we're going to talk about, you'll see that 2012 was the first time in 5 years that a new record wasn't set. But I'd argue that with anywhere between 100 and 200 new drug shortages, something has to give. Okay? And look, this is very timely. This is up to just not even 2 weeks old. So Aaron did good. Here are the number of active drug shortages each quarter in the United States. So while there have been fewer new drug shortages each year, our inability to resolve existing shortages is why there's still 301 drugs currently in short supply as of 13 days ago. Okay? I think this is probably one of the most important slides I'm going to show you today. What you're seeing here is the top 5 drugs by drug class that are in short supply. And yes, you can see that there's 24 chemotherapeutics that are in short supply. But really, I think the take-home message is it doesn't matter what kind of a patient you are, cancer, rheumatology, orthopedics, infectious disease, or what kind of physician you are, you're going to be impacted by these drug shortages. While the reasons for the shortage are multifactorial, most experts agree that the primary causes are economic, manufacturing and quality issues, and regulatory. And so what I'd like to do is spend a few minutes and talk about each one of these, because I think understanding why these shortages happen obviously is very important in terms of how one goes about coming up with solutions to deal with them. So historically, oncology practices, and this is medical oncologists, doctors who take care of adult patients with cancer, they bought chemotherapy drugs at a low price and sold them at a significant profit. And this resulted in skyrocketing prices. So in 2003, in an effort to curb the high costs, the federal government stepped in and passed the so-called Drug Act. And what the Drug Act did was, it set a ceiling on Medicare reimbursement of sterile injectables based on this complicated formula called average sales price plus 6%. Maybe not so complicated. And let me give you an example of what that looks like in the real world. So before the Drug Act went into effect, a month of a frequently used chemotherapeutic called carboplatin was reimbursed at $1,845. After the Drug Act went into effect, half of that, $930. Still some profit, okay? Paclitaxel, a drug that the adult oncologists use frequently. A month of it, pre-Drug Act, was, reimbursed at $2,270. After the Drug Act went into effect, 10% of that, $225. And then etoposide, our friend, pre-Drug Act, a month was reimbursed at the relatively low price of $111 a month. After the Drug Act, you can barely see, $11 for 1 month. Excuse me. So typically, a shortage results in increased demand that drives up prices. But by setting a limit on reimbursement, the Drug Act is actually one of the things that's contributing to the shortages. And all you got to do is go back here and see, in 2004, there were only 58 drugs in short supply, and by 2011, there were 267. So as a result of this, some pharmaceutical companies may have less of an incentive to produce these cheaper generics, and they may divert production to more profitable brand name drugs. And this is exactly what happened. So I'll give you an example of that. In 2008, the FDA approved a drug called levoleucovorin. It's a brand name drug. It's no more effective than its generic cousin leucovorin, except it's 58 times more costly per dose. And people started prescribing it so much that it too became short. We have to keep in mind that unlike other countries that set national wholesale prices for each drug, Here in the United States, we leave drug pricing, including generics, up to market competition among pharmaceutical companies. But this idea of competition, it's a bit of a non-issue. You see a surprising number of these life-saving drugs are made by a single company. So there's no competition, and they can charge whatever the heck they want. And also, as many of you know, Medicare, the largest government purchaser of healthcare, isn't allowed to negotiate drug prices here in the US. As there's often a single major supplier of a particular drug, quality control issues in that production line, that conveyor belt as it were, have an enormous impact on that drug supply. And there's little backup. So 7 companies produce all the sterile injectables we use, not just chemo, everything else. And 3 companies in particular sell 71% of all the injectables, and all 3 have had problems in their production lines over the past few years that have impacted supply. And things have actually started to get much worse. So at the end of last year, one of the companies called Benvenue or Benvenue, depending on how you prefer, a major maker of generics, shut down. And previously it was the sole supplier of important chemotherapeutics like methotrexate. At the time of its closure, it was still the sole supplier of drugs like Doxil and Thiotepa. And experts believe that Benvenue's closure alone is going to tack on another 4 to 6 years of these shortages. And you saw the number of active shortages are going up. Also, often more than one drug is made on the same production line. Those production lines are pretty onerous to maintain, and so the manufacturers like to get the most bang for their buck. So if there's a problem with that line and there's only 1 or 2 companies that make that drug, then usually more than one drug is impacted. We have to keep in mind that before July of 2012, pharmaceutical companies weren't required to tell the FDA about a production problem. So the authorities found out after the fact from hospitals or individual doctor groups. Now, if you think about this from the pharmaceutical company's perspective, they're a business. They have a bottom line to attend to. Why are they going to acknowledge that there's a problem in their line when it will give their competitors a leg up? But really, the deeper issue here is a lack of transparency. You see, pharmaceutical companies oftentimes contract other companies to make their drugs for them, but it's not publicly known who makes what for whom. So knowing what the real supply chain is nearly impossible, and I'll give you an example of that. So Boehringer Ingelheim is a German company. They're the parent company of this Benvenue company, and Benvenue was recently sued by another company, Johnson & Johnson, to continue to make Doxil one of its drugs. This is very convoluted. And also because of the varied distribution of drugs nationally in the United States, drug shortages happen at different times, at different places, and at different rates across the country. So in 2011, there were 13 states, including Maryland, that had much more shortages than neighboring states did. So it's a very convoluted and complicated system. Here's just a schematic representation of what I showed you about this consolidation within the marketplace. And you can see when it comes to chemotherapeutics, 3 companies supply the brunt of the market. So when one of them has a problem, we definitely all feel it. So according to pharmaceutical companies, they say that the drug shortages are the result of overly burdensome FDA inspections that cause delays in manufacturing. But the data doesn't support that. The data is pretty clear that these are manufacturing quality issues, economic considerations, etc. But let's talk a second about the FDA. So historically, the FDA had the relatively easy job of just making sure that the drugs we use here in the States are safe and effective. They now find themselves in the unenviable position of monitoring these shortages. So how many people here know that the FDA has a drug shortage program? Show of hands. Few people. So they do, and it's staffed by 11 full-time employees. Count them, 11. And these people are working like crazy, and they monitor shortages only of what the FDA defines as a medically necessary drug, that is a drug that's used to treat or to prevent a serious condition for which there's no alternative. It's not that they don't want to monitor all shortages, they simply don't have the staffing to do so. And this is why if you go back to that micro font slide I showed you with the FDA's page and the ASHP's page, the drugs that are listed on the 2 aren't necessarily the same. It's important to appreciate what the FDA doesn't have the authority to do. They can't go to non-US manufacturing sites where we get most of the raw ingredients we depend upon to survey them. They can't require the companies ramp up production. They're not even allowed to disclose why there's going to be a problem with a particular drug. Now, one positive step was that on July 9, 2012, President Obama signed into effect the FDA Safety and Innovation Act. And this act accomplished really 4 things. It requires the manufacturers to notify the FDA as soon as they know about a particular problem, or even if they think there's going to be a problem. And failure to do so will result in an official letter being made available to the public, essentially no press like bad press. Importantly, it gives the FDA the authority to expedite review in the hope to avert a shortage, and it required that the FDA submit a strategic plan to Congress on how they were going to cope with the shortages, and they did this on Halloween of 2013, and there's an interesting story to this that I'll tell you about in a bit. So I'm sure some of you have heard about the shortages, or hopefully you've heard about the shortages. It's gotten varying degrees of coverage. I'd argue not nearly enough, but it's been in the lay press and the academic press. So here's what a physician at Sloan Kettering, Peter Bott, has to say. He was actually profiled after he said this 60 Minutes not that long ago. And what Peter has to say is, our regulatory and approval system seems constructed to achieve high-priced outcomes. We don't give any reason for the drug makers to charge less, so economic issues. This is what a group of very thoughtful scholars talk about the reasons for the shortages. They state, drug shortages stem in part from choices that we as a society have made about how we want to organize our markets, our regulatory systems, and our health services. The authors go on to state, to prevent drug shortages will demand moral trade-offs and reordering priorities. So we're getting some ethics speak in there. So as we saw, drug manufacturers earn a lot of their profit here in the United States where prices are uncontrolled and where Medicare isn't allowed to negotiate drug prices. And you can see from this first bullet, when it comes to some of the drugs like chemotherapeutics, the price has risen over 14% just last year alone. And I like this last bullet, which is a quote from a pharmaceutical economist at the University of Minnesota. He called it the wild, wild west of drug markets. Okay? I'm sure some of you are familiar with Zeke Emanuel, older brother of that dude from the Entourage show, Ari Emanuel, older brother of that dude who's the mayor of Chicago, Rahm Emanuel, and probably the smartest one in the whole family who you never hear about, their sister. So Zeke is a medical oncologist, but he's probably more well known for his work as a bioethicist. He's at the University of Pennsylvania. He was a policy advisor for President Obama. Here's what Zeke has to say about the shortages. The sad fact is there are plenty of newer brand name cancer drugs that don't cure anyone but just extend life for a few months at costs of up to $90,000 per patient. Anybody feel lucky and want to guess what drug he was talking about? Bevacizumab or Avastin. Okay? He goes on to state only the older curative cancer drugs that cost as little as $3 per dose, think etoposide, have become unavailable. Now Zeke made a statement over 3 years ago, and one would think that maybe things have gotten better, but they haven't. So I'm sure some of you have heard about these new drugs to treat hepatitis C. These are game changers. They actually are very important, but they're very costly. A 12-week course costs $84,000 per patient, and some patients require double that. So health economists have estimated that if all 3 million people in the US who are infected with hepatitis C are treated at an average cost of $100,000 a year, the amount of money we're going to spend on prescription drugs in the US is going to double from $300 billion to $600 billion each year. That is unsustainable. I can't even think about how many zeros that is. There's new drugs that are come out, also potential game changers to treat diseases like malignant melanoma, $150,000 per patient per year. Now obviously fewer patients with melanoma thankfully than hepatitis C, but that's a lot of money. And then in my world of pediatrics, new drugs to treat cystic fibrosis, $300,000 per patient per year. Just ridiculous amounts of money. Bear with me here, folks. Good. But this isn't only a cost issue. Lives are at stake. So in 2009, and my colleagues from Pizan probably remember this, there was a shortage of a chemotherapeutic that had been around forever called mechlorethamine. And we use that drug, among other things, to treat some adolescents with Hodgkin lymphoma. So at the time of that shortage, evidence suggested that another old tried and true drug called cyclophosphamide was as effective as mechlorethamine. So a number of kids got the alternative regimen that included the cyclophosphamide instead of the standard mechlorethamine. The 2-year event-free survival of the kids who got the alternative regimen was 12.5% lower. And while there were no deaths, these kids got exposed to considerably more rounds of toxic chemotherapy as well as stem cell transplantation. and go back to that slide I showed you of the human body and all the side effects that some of our drugs can cause, okay? And this prompted the authors of that study to state what you can see here. Even promising substitute regimens should be examined carefully before adoption. What might appear to be a suitable alternative regimen may result in an inferior outcome. And for those of you who prefer to see this on a graph, you can see with the blue being the alternative, less effective cyclophosphamide. We also have to keep in mind that it's shortages of chemotherapeutics more than any other class of drugs that's in short supply that impacts patient safety. We're not as familiar with that drug, the toxicity profile, how it interacts with some of the other regimens we use, so this is a major patient safety issue as well. Here's data on the impact of the drug shortages based on a survey of adult medical oncologists, and this was published in the last issue of New England Journal in 2013. And what you can see is a staggering 83% of the oncologists said they'd experienced a shortage over the past 6 months. Over 3/4 said that they weren't able to prescribe their preferred regimen or they had to make some substitution during treatment. And over 40% said they had to delay the start of treatment. So imagine that you're an adult and you go to, or a kid, and you go to your doctor, and sorry to tell you, Mr. Jones, you have cancer, but I can't treat you, or I can't treat you the way I want because of these shortages, okay? What I find particularly staggering is, even though these shortages have been around for 10 years, 70% of the respondents said that their hospital or group lacked any type of guidance about how one goes about ethically allocating these drugs. So there's the grant question, right? That's what you go to your funders and you say, look, this is real world, man. And there's another paper that just is coming out this week. It's in EPUB print before it reaches the publication in Journal of Oncology Practice that is having very similar numbers. 75% of oncologists experience a shortage. 28% of them said they had to use a less effective alternative. Exactly what you want to hear when you have to deal with a life-threatening illness, right? So this raises a host of ethical questions, okay? For institutions, for clinicians, what do we do? Do we delay treatment? Do we skip a dose? Do we do something else entirely? Should we prioritize patients? And if we do prioritize, what might that look like? The individual bedside physician or a neutral panel? So we like to do thought experiments sometimes in ethics, so let's kind of play this out. In pediatric oncology, we use methotrexate, among other things, for kids with ALL, the most common cancer in kids, and osteosarcoma, the most common bone cancer. So the average adolescent with osteosarcoma requires 20 grams of methotrexate per cycle. And there's 12 of these cycles typically. That same 20 grams could be used to treat anywhere from 1,300 to 2,000 kids with ALL for CNS prophylaxis. So does that mean that the kid with osteosarcoma's life is worth less than the kids with ALL? Maybe we prioritize kids over adults. Works for me, I'm a pediatric oncologist. In fact, this is what happened at Sloan Kettering a couple of years ago. They diverted their limited supply of a drug called daunorubicin to kids over adults. Now that works for me unless I happen to have cancer or my wife has cancer, right? How about first come, first serve? Seems to do away with some of those sticky ethical issues. Well, I'd argue first come, first serve probably is not the best way you want to allocate. So let me give you a few examples why. So I told you that I grew up in Israel and I'm always hot. Well, I also drive my car like an Israeli, which means get out of my way because I'm coming hard and I'm coming fast. Now, I also happen to have a fairly fast car. Let's say that I know about the shortage and Cinda does too. And Cinda relies on public transportation. Trust me, I'm getting to the hospital a hell of a lot faster than Cinda is, and that just doesn't seem right. I'd also argue that you all, by virtue of sitting here and listening to this talk, now have insider information, as it were. And somebody who wasn't here or who didn't read the press and doesn't know about it, you guys can now act on this in a different way, and that also doesn't seem the right way to allocate this thing. And I'd argue that first come, first serve, probably the biggest problem with it is it doesn't take into account need or prognosis. So kids with ALL have a very long treatment course. Depending on the type of ALL, it's oftentimes 3+ years. I'd argue that a kid with ALL at the beginning of her therapy is very different than the same kid at the end of her therapy, and the kid at the beginning may need that drug more. So it doesn't take into account those issues. I've shown you lots of data on the impact on clinical care. But remember those cool slides I showed you about how we've gotten better over the decades curing kids with cancer? Well, that's because we do research. And the same drugs that are in short supply that we use to treat kids are part of our research backbones. How are we going to continue to make substantive observations if we can't do research? What's it going to do to our ongoing trials? That suddenly there's a drug shortage and the trial is a year and a half, 2 years in, and suddenly you don't have the drug. I mean, this is a nightmare. I'll talk in a second about the role of institutions. There's this idea of the alternative agents we saw with cyclophosphamide and meclorethamine. Even when we think that there's an effective alternative, it doesn't necessarily pan out that way. But I also have to mention the gray market. So how many of you have heard about the gray market? More people. Okay. For those of you who may not have, the gray market are a group of unauthorized secondary drug distributors that profit from the shortages. And economists have estimated that the average markup of a drug sold on the gray market is 650%. So it's just like you go to that Springsteen concert and you didn't get tickets and you got to get tickets, you will pay, right? And we're not talking about the boss, we're talking about life-saving drugs. But take a look at this data. So here are the top 10 highest markup drugs sold on the gray market, and 3 of the top 4 are chemotherapeutics. So cytarabine or aracene dexamethasone marked up nearly 4,000%. Leucovorin over 3,000%. Okay, big bucks. So these are the headlines we want to avoid. This is a very busy slide, and I don't expect you to be able to see it, but I do want to point out a couple things that I agree with wholeheartedly. What some of the commentators have said about drug shortages. National emergency, natural disaster. Okay? In fact, one person stated national disgrace. And remember, we're talking, this tends to happen much more here than it does in other places. So let's segue and talk about coordination. And he's not here, but my colleague, sometimes office mate, Matt DeCamp, shared some of these slides with me. And Matt is a member of our working group, and I want to thank him for helping me out. So I think it's pretty clear that we have to prioritize drug. But here in the United States, prioritization is a 4-letter word, right? What is the next thing that oftentimes comes out of people's mouths when you say prioritization? You're one step ahead of me, but rationing, right? And then the next thing that they say, especially if you can wave to your friends across the Bering Straits and your former governor, then the next thing that you say is what? Death panels, right? But joking aside, we ration every day in the United States healthcare system. Insurance companies ration all the time when they approve or disapprove of a medication, a procedure. This is a form of what we call implicit rationing. Another form of implicit rationing is a patient's ability to pay. Explicit rationing are things like allocation of organs, hemodialysis, things like that. So rationing, I think, is going to happen. It is what it is, but I'm not sure that bedside rationing is the way we want to go. Of course, in the heat of the moment, each one of us is going to advocate for our patients. But not only is it inefficient, it's idiosyncratic, it's not very comfortable. And so this is why a lot of hospitals and institutions have their own prioritization plans. And there's one here, and there's one at Sinai where I do my clinical work, but not everybody. So we purport to practice evidence-based medicine. What does the literature tell us? Well, in this busy slide, what you see is what 4 thoughtful groups have said about how to go about allocating a scarce drug. So you can see all 4 agree that the most important value or primary value is really save the most lives, okay? You can see that they all say we should not just favor the worst off. After that, though, it gets a little sticky. Some of them say definitely first come, first serve. Some say definitely not. And one of them, probably the most honest, kind of raises their hand and say, we have no clue. And the same thing goes for lottery. There's this idea of reciprocity that let me talk about in a minute, but I'm getting hot, so I got to take off my jacket. Would it take about 25 minutes? So I took off my jacket, that's pretty good. If my mom calls you, tell her that I had my jacket on the whole time. She'll be very upset, my Polish Jewish mother. So, in pediatric oncology, one thing that we need to think about is, since so many kids participate in clinical trials, should they get priority access, right? The other thing that we need to think about is, yes, kids with cancer need methotrexate, but so do kids and adults with rheumatologic diseases, so do some GYN patients, so do some dermatologic patients. Who's to say that the bald little kid with cancer is any more deserving than these other sick patients? I mean, these are all things that we need to consider. So given that there's no agreement about the so-called best way to prioritize, it seems as though another approach is needed, and specifically that would be coordination. In fact, 2 of the 4 people I showed you on that busy slide appreciated this. So Phil Rossoff and his group at Duke talk about forming regional consortia of hospitals to pool their scarce resources. And Gibson and colleagues up in Canada talk about redistributing drugs within care settings in coordination. So given that there's these mumblings about a need to coordinate, how come so far this hasn't happened? Well, that's a whole other talk. That's next year. But here's one of the reasons why. So we've all been in this scenario. You've just gotten off your flight from New York to Tel Aviv. You've been crammed in like sardines. It is hot like you've never seen before. You're 10 feet deep at the baggage carousel, and your bag's whirring by, and nobody's taking a step back. Okay, so this is one of the reasons why. So, motivated by work within the Children's Oncology Group Bioethics Committee that I sit on, and supported by a generous grant from the Berman Institute, we brought together this very sexy name, the Working Group on Chemotherapy, Drug Shortages, and Pediatric Oncology. It's a mouthful. And our goal really was to come up with core ethical values and practical actions needed by institutions, agencies, and other stakeholders to respond to the chemotherapy shortage. And we convened a multidisciplinary transnational working group. And you can see the type of people who were members of our group. We had clinicians of all flavors, we had folks with expertise in bioethics, we had legal scholars, we importantly had patient and family advocates or representatives. FDA was there, of course in an unofficial capacity because that's what they have to say. And then any of you who've tried to do something like this can appreciate you gotta have leadership involved. So Ruth Faden, the director of the BI, was a part of our working group. Peter Adamson, the chairman of Children's Oncology Group, and Kim Ritchie, the president of the American Society of Peds Hem-Onc, were all members of our group. And here are the members, and you can see some people who are sitting in this room. Ken Cohen over there, Ken, raise your hand, was a member of our group. There's some other folks from Hopkins. So really, we had a fairly broad group. So we sought to endorse two core ethical values. We sought to maximize the potential benefits of these life-saving and effective drugs. And we wanted to make sure that we did this fairly. In other words, that there was equitable access across institutions to these drugs. And it became clear to us pretty early on that the only real way to do this effectively was by coordination, playing in the sandbox, okay? So rather than focus on prioritization that had already been explored, our goal was novel ways to prevent or to mitigate the drug shortages. Now, for those of you who are paying attention, you'll remember that I told you about the FDA Safety and Innovation Act and that they had to submit a strategic plan to Congress. And they did that when? Bueller? Really? No? Halloween! 2013. Prize for the man in the second row. Yes. Guess what the FDA's strategic plan was, the crux of it? Novel ways to prevent and to mitigate the shortages. Now, FDA members were at our meeting, were writing furiously, and did they borrow from us? Hopefully, but they appreciated that this was what was necessary. Now, I don't have time to go into each one of these recommendations has sub-recommendations and practical barriers, but in the next 10 minutes or so, I do want to give you a little bit of a taste, and then there'll be some time for questions. If you're really interested in it, you can read about it here. So this is playing with PowerPoint. So I think it's fair to state that most sensible people agree that when it comes to life-threatening diseases like cancer, people should have reasonable access to life-saving drugs. So minimizing the barriers that are in that way makes sense. So a couple of our recommendations in this regard is thinking about maybe having a stockpile of drugs nationally. Now we also talked about amending the Drug Act. So I'm sure in this day of pandemic, or not pandemic, but of epidemic flu, many of you know that CDC has a stockpile of ventilators. They have a stockpile of oseltamivir or Tamiflu to treat people with flu. They have a stockpile of other drugs like ciprofloxacin in case there's an anthrax outbreak. So how come there can't be a stockpile of these drugs we consider important? Now there may be some disagreement. Cardiologists might say epinephrine, and anesthesia might say propofol, and my pediatric oncology colleagues and I would say methotrexate, but I think we can maybe get to a consensus. I think the harder part here is amending the Drug Act. Remember, the Drug Act is that thing that reimburses for Medicare sterile injectables based on average sales price plus 6%. R&D, as the manufacturing companies always tell us, maintaining production lines, all of that is very costly. And at the end of the day, these companies are businesses, and if they don't see an investment, a return on their investment, they have no desire to continue making the drugs. So maybe if we pay a little bit more for some of these cheaper generics, they'll have an incentive to continue to make them. And this is what happens in the rest of the world to a much greater degree. For example, in Europe, they pay more for generics, much less for brand name drugs, and this is one of the reasons that there's not the same degree of shortages. Now, in a free market economy like ours, we can't mandate that, but it's something to consider. So sound medical care demands that clinical decisions be based on rigorous evidence and optimal resource allocation. And that's really true during a shortage. And here what we talk about is really focusing on using drugs which there's only data to support doing so and avoiding the gray market. And the context here is the IVIG shortage that some of you may recall who have more gray hair back in the late 90s. So in 1997-98, there was a shortage of this drug called IVIG. And it's one of these drugs that lots of different types of doctors, oncologists, neurologists, rheumatologists, internists use, and not all of the uses are based on good data. So at the time of the IVIG shortage, much of it went away once IVIG's use was restricted only to which there was good data. Now what's one of the downsides of this? Just because there may not be data to support that drug's use, it could still be helping some individuals. So we run the risk of harming some minorities, right? The other thing is we come down pretty strongly against not using the gray market. So remember, that's the scalpers in healthcare. That's the healthcare version of getting your boss tickets, at Verizon Center a minute before the concert's about to start. So there's some fairly good data that shows that the gray market is one of the contributors to the shortage. Not only did they hoard drugs, I'm not even talking about the fact you don't know what the pedigree of the drug is, how it was stored, how it was transferred. Well, what's one of the potential downsides if we have that policy? Imagine that you're the doctor taking care of a kid with cancer, or even worse, the parent or the kid, and your hospital doesn't have a drug that you need, but it's available on the gray market. Are you really going to tell that kid, no, you can't go get it because that's our policy? These are some of these tough questions we got to think about. This next recommendation was the one that probably resulted in the most heated debate within our working group, and it focuses around this idea of reciprocity. So ultimately, the majority of kids with cancer participate in a clinical trial at some point during the course of their illness. And this is relevant because fairness requires sharing the benefits and burdens of research equitably. And we want to make sure that kids and parents decide to participate in research freely because that's what's right for them and not because they feel pressured to do so. And at the end of the day, our working group felt that kids who participate in trials should not get priority access to scarce drugs over those who do not. And the main reason was this potential for what we call undue inducement. We don't want kids and parents to fear that they'll be denied access to a drug unless they participate in research, right? You want them to participate in research because they feel that's what's right for them, based on their values, based on their preferences. But at the same time, we do owe them something, right? Research is risky. That's why it's voluntary. Research participants are taking one for the team. They're contributing to generalizable knowledge. They may or may not benefit. They may do worse. And so I think a moral argument certainly can be made that research participants are owed something. But at the end of the day, our working group felt the concerns over undue inducement, public perception, and really focusing on using drugs for which right now there's evidence to show that they're effective outweighed this idea of reciprocity. But we went back and forth on this for some time. Fairness requires that there be equitable access to drugs across and within institutions. And because some hospitals may fare off better than others, some patients may not do as well depending on where they show up. So really what we're talking about here is leveling the playing field. Anybody can go to the FDA's website and the ASHP's website and find out how many drugs are in short supply. But a lot of the information about drug supplies, where you can get another drug, how long it's going to last, is behind the scenes. Social media, informal contacts, my cousin Jack who's in the alley back there, okay? And some hospitals have deep pockets. They employ 3, 4, 5 full-time pharmacists who all they do is focus on the gray market. Others don't have those deep pockets. And if you show up to one of those places that doesn't have as deep pockets, as a patient, that just doesn't seem right. And so what we want to do is we want to make sure everybody has the same information at the same time. Well, what's one of the problems with that? Think about what happened at the supermarket last night when you heard about freeze warning. What was there a run on? Toilet paper and batteries, or in my house, coffee and hot sauce, right? People hoard. Oh my God, there's going to be a shortage. I got to stock up. Well, this happens in healthcare. Trust me. So I sit on my hospital's drug shortage committee, and we sit in the most secure room in the hospital. It's like one of those Mission Impossible movies. You've got to wave your hand, and your badge doesn't work, and you have to stand on one foot, and then they buzz you in 3 doors. And lined on the walls of our meeting room are boxes of scarce drugs that are being saved, okay? And every hospital does this, trust me. There's this study that came out recently that showed that 85% of hospitals purchase excess inventory. That's what they call it. We purchase excess inventory. Well, that's hoarding, okay, in response to a shortage. But everybody does it, right? Because the CEO of the hospital doesn't want the headline that says, Sinai Hospital, Johns Hopkins Hospital, didn't have enough drug to treat bald little kid with cancer and had to go to MD Anderson. I mean, that does not look good, right? So wrapping up, just a couple more here. So during a drug shortage, some hospitals may have relative surplus and others may have scarcity. And so in these settings of maldistribution, sharing of drugs between institutions would not only improve outcomes of individual patients, but it would deal with some of these social inequities, right? Right now, unfortunately, there's a lot of barriers that prevent sharing of drugs, including laws that say you can't transfer a drug even if you've got a willing place in Delaware who wants to send you their drug, okay? Now, some of you may recall that 2 years ago and then last year, there was an outbreak at Princeton and then later University of California, Santa Cruz, of bacterial meningitis caused by strain B. And that strain was not covered at the time in the US vaccine against meningitis. So what ended up happening was actually brilliant. Two gargantuan federal organizations, CDC and FDA, got together and they allowed to import a Swiss vaccine that did cover it. And that's a wonderful example of how maybe those types of things can be done. Also, since our recommendation came out that we should allow sharing, the Senate on November 27th of 2013 passed the Compounding and Track and Trace Bill. This is an electronic measure and it allows a drug to be followed from its point of origin to its point of distribution. And the hope is that as this becomes more widespread, some of these concerns about sharing of drug and how we're going to follow the pedigree will be alleviated. Now let's say that it actually works, that these laws are taken off the books. What might that look like though? Let's say that I call David Loeb and I say, David, I need methotrexate. He says, no problem, Yoram, and he sends it to me. And then I call Ken a month later and I say, Ken, I need daunorubicin. He says, no problem, Yoram, sends it to me. And then they call me and I'm like, I don't pick up the phone. How are you going to enforce this, right? I mean, should there be some kind of stick in place, not just the carrot? And again, these are some of the questions that we need to think about. The last recommendation really is the one that makes the most sense, but just hasn't gained enough traction. And it involves stakeholder engagement. So a lot of the decisions about how these things are done, I told you, happen in double, triple secret rooms and badged access and involve doctors and ethicists and pharmacists and social workers, but not enough include the people who have most skin in the game, which is the parents and the kids, obviously. And so really, we want to make sure that they're involved in these discussions because they have something meaningful to say. So to conclude, hopefully I've been able to convince you that solving the drug shortage problem isn't only an ethical obligation, it's a practical one. And hopefully I've also been able, I hope, to show you that yes, rationing is important, but really we should focus on coordination. And the reason for that is simple. Coordination will not only allow us to meet the needs of our current patients, but some of these larger important societal issues. And we feel as though our recommendations are a kind of blueprint of sorts to prevent kids and adults with cancer for lacking access to these life-saving drugs. And yes, our focus is on childhood cancer, but I think the principles are a little more broadly applicable to medicine in general. And there's a lot of work that still needs to be done, right? We need to engage not just institutions and clinicians and parents. We didn't include industry in our working group on purpose, but they have skin in the game and they need to be involved, professional organizations, etc. So I want to leave you with a quotation from one of the journals that I read called Pediatric Blood and Cancer. And this was talking about treating cancer in the so-called developing world, but I think it's very apropos for us. And you can see the authors here stated, failure to treat life-threatening diseases such as cancer represents a violation of the fundamental rights of children and of the professional duties of the wider healthcare community. And my daughter thought that looked like me. It says, we're looking for a new supplier, generic drug shortages. So I think we have some time for questions. Thank you. Or not. Yeah.
At what point are you going to engage? At what point are you going to engage the pharmaceutical industry? And why did you decide not to include them initially?
So the question was, when do we engage pharma? and why didn't we decide to include them originally? So path of least resistance, we really wanted to focus on the academic discourse and some of the practical issues. Pharmaceutical industry obviously has commented upon the drug shortages, and they are by no means the only reason, but they're one of the reasons for the shortage, and they have a different view. I mean, I think, unfortunately, until there is another tragedy, much like the New England Compounding Company that had the tainted steroids and people got fungal meningitis and died, or, I mean, there have been deaths due to these shortages, but until that happens on a broader scale, there's not going to be enough oomph, and people aren't going to at the pharmaceutical company, and they're a powerful lobby, and again, they're businesses. I mean, we need them. We can't make these life-saving drugs without them. So that's something that, you know, is in the works. It's not something that I look forward to, but it's something that we have to do. Nancy.
Thanks, Yoram. Really, really great talk. I have a few questions, but I'll limit it to one here. I'd love to hear you talk a little bit more about what you described as a really difficult debate within your group about the trial participation. And I want to say two things and ask them what you think. One is I'm really interested in what you mean by trial. Right, because there's trial where people get, for example, randomized to this or randomized to something that everybody believes is inferior, placebo, and there's trial used loosely, which means you have to commit that we can collect data on what's going on. And particularly when you frame this as well, research is where it's risky and where you put yourself out for somebody else at the cost to yourself than option 2, where we just say, okay, we're going to give you the drug, but you have to commit that we can learn from whether or not the drug actually makes a difference for clinical conditions like yours. To me, doesn't require any clinical sacrifice. So anyway, I just love to hear more what you were thinking about there.
So that's a great question, and initially in our discussions, we failed to appropriately define what we meant by kids on research. When we fleshed it out, the understanding was that but what we mean by a kid on research is when you're comparing a standard of care usage versus a novel approach. Now that could be something that's in a phase 3 trial, which is often what kids with cancer and upfront therapy do, where it's a very minor tweak, right? And that's very different than a kid in a phase 2 or a phase 1 trial where even the goals of research are very different. But in the discussion that we had, it was specifically not just collecting data, but it was the novel application or approach for using a particular drug. And a lot of the people appropriately in our working group felt COG, and this was, remember, this Children's Oncology group, although there were many participants in our group who weren't COG members, that was kind of the primary audience. So people within COG said, we are a clinical trials organization. We are a cooperative research group. That's what we do. So it's almost as though we're not being consistent with ourselves. But at the end of the day, we really felt that in order to continue to do what we do well, we couldn't prioritize these kids. Now, I'm sure that some of my colleagues have had similar experiences as I've had parents at the time when the shortages were really acute come up to me and said, I don't like this trial, but I want to enroll because I think I'm going to get drugged that way. And we never told them that. And we couldn't guarantee that. And so again, this idea of having people on trials, if that's not what they feel is right for them, I'm happy, we can talk some more about it afterwards. I know there's a couple other questions. I don't know if that answers your question directly, but the idea really was a novel usage of a drug compared to a standard accepted approach.
I have a question from the family perspective. What percentage of the rising costs that you described today does the family end up shouldering, either out of their own wallet, out of their health plan? What are they seeing coming to their house that their health insurance doesn't cover? Do you have any idea what percentage of these costs is looking at the family on their dining room table every month?
So the honest answer is I don't know. I do know that it depends on each individual family's plan.
Right. I understand it's a really broad, but I just wondered if you had any.
I don't know. I can tell you that I've had patients, parents bring me the bills they get from the insurance company, and after a multi-year treatment, it's in the hundreds of thousands of dollars. How much of that is their cut? I think it depends, and I don't know. I apologize.
I mean, do you have families who just don't know how they're going to continue?
Yeah, and most centers have so-called rainy day funds, and there's federal assistance programs. They help, but they are by no means comprehensive. But every center I've ever been affiliated with or know about has some. I mean, we will treat anybody, and oftentimes what ends up happening, and the parents understand this and accept it, of course, but then you're not thinking about the money necessarily at the time when you have to have these discussions, but and treat, but it comes back and bites them. But I don't have data. I apologize on the cause. Renee?
So thanks, Yoram, for raising our consciousness about these things. And I was thinking about how often it is that I get emails here saying that some drug is already in or tomorrow is going to be in short supply, acyclovir, heparin, whatever it is. And
You're not using much methotrexate in the NICU?
Not as much, no. But you made the comment earlier about how often these things work in your favor, right? So in the NICU, often these things work in my favor because it turns out apparently the babies get prioritized a lot, because what it tends to say is, well, we have a shortage of acyclovir unless you're a neonate. You have made me think about that I'm not actually clear who's rationing the drugs inside my institution, and I'm also reasonably plugged into the ethics community, both in the Bioethics Institute and the ethics committee here, and I'm aware that I'm not sure if my colleagues are sitting on those committees that are rationing these drugs, and how did babies get prioritized, and so what's up with these committees that is deciding that the babies get the drugs?
It's a very exclusive
Who are you
club.
people?
It's a very exclusive club, and there's a special handshake. So I don't sit on the Hopkins committee. I don't have any clinical work here. I know some of the pharmacy people are on that committee. Ken, do you know, is Alex still on the prioritization ration committee? Alex
I
Dad?
don't know how it works in other areas, I have to say. I mean, generally for most of the shortages that are oncology related, we sort of convene a group that's based on stakeholders who, have some interest in that particular agent or use it a lot, and then we at least make some internal decision. But I don't have any idea how it happens beyond doctors at all.
I can tell you what happens at Sinai, because I'm the vice chair of that committee. We have a very similar approach. We have a group that we feel represents most of the stakeholders. So we have clinicians, nurses, social work, bioethics folks. We have, because the hospital wanted it, risk. We have patient advocates. I was adamant that we have a couple parents involved, although oftentimes they're not able to get there when we have to make a quick decision. And then the members of pharmacy, obviously P&T are there. And then we make a decision based on what we have an algorithm, and oftentimes the algorithm goes out the window and emotions fly, and we try not to let that happen, but it does. And then we make a decision that we then vet with, for example, if it's going to affect pediatric oncologists, we then talk to the chief of those divisions and the other immediate physicians who are involved. Not necessarily for them to tell us it's okay, because they don't get to veto that, but to let them know. And then we offer the patients who are affected the ability to come back to us and say, you know what, you're on crack, I need this drug, and blah, blah, blah. Yeah.
Is there anybody in this room who's associated with the Hopkins drug rationing, the general hospital drug rationing group?
They could tell you, but they'd have to kill you. Yeah, sir.
So you mentioned that there's a trend for why drugs fall into a shortage. With the unique cases where a drug does become resolved, is there a trend for why it became resolved?
So the question was, we know the drugs get short, but what about when it's resolved, and is there any type of thing we could look at why it gets resolved? So it could be a lot of things. It could be that there was a relatively minor problem with the production line, if it was a manufacturing quality issue and the company has resolved that they had faulty equipment and they got dinged by the feds. It could be that, for example, with the Bend venue closure, the government has been working with other companies to try to step up to the plate and produce those drugs. Now, it takes a lot of time. You've got to get not just the resources, but you've got to get a new production line. You need to be accredited, you need to be certified, all the safety stuff. So sometimes you have another company that's stepping up to the plate. And then sometimes the company just decides, you know what, we got a lot of bad press, or we made a bad decision, or, yeah, more than one answer.
Actually, it's interesting with the Cytarabine shortage we had a few years ago, you talk about sort of regulatory issues. Well, it was actually parents' pressure on the FDA that helped to get the production lines reopened because it was a manufacturing issue.
Same with methotrexate. And COG was pushing behind the scenes, not so much behind the scenes. FDA also will import drugs from other countries. They don't like to do it, but they will. They did that with Doxil. They did that with some other drugs. But that's some of the other countries are thinking, why am I going to give you drugs when I can now run out? And they oftentimes also, the way that these drugs are negotiated, the contracts with companies, sometimes it's built into the contract. You're not allowed to ship your drug elsewhere. So again, some of these barriers. Yeah, Joe.
Yeah. I was wondering if you could say maybe a little more about what must be a pretty uncomfortable conversation with families when there are shortages. Is it always the case that these things are raised in discussions with families, or are there some circumstances or instances where you may not raise it? So I'm wondering if there's a delay in the use of a certain drug, and obviously that conversation looks like it would happen. If there's a shortage or a short supply and you can revert to another drug that's almost as effective, but maybe not quite, do you always have that conversation about the shortage, or do you have a sense for how often that comes up in clinical practice?
So I can tell you, based on obviously what I know, what happens with my colleagues where I work, I can tell you based on what we had spoken about at our working group and when people shared their stories. One of the things to keep in mind, though, and then I'll answer your question, is there's very few alternatives. We in pediatric oncology are very data-driven. We are hesitant to use drugs unless there is good research to support why we're using that drug. I mean, these drugs don't come for free, and I'm not talking about their cost, I'm talking about their side effects, their toxicities, and we like to use drugs in a very thoughtful and appropriate fashion. So alternatives is not all that common. It's not like the patient with rheumatoid arthritis who needs methotrexate, but if there's not methotrexate, they can use a TNF inhibitor or an NSAID or something like that. And remember, the goal here, unlike, for example, and I'm not picking on rheumatology patients, but quality of life is essential and it's important, but that's very different than survival, right? And so, as far as the discussions, when I've had to have those, I'm very honest, and it's not easy. And the parents are one of it's the cartoon where the mouth kind of, are you kidding me? What do you mean you don't have a drug? What do I need to do? Who do I need to call? And it's something that if we have to use a less effective drug, I imagine that Ken and David do the exact same thing. I mean, the last thing you want to do is lose trust, your patient's trust, and when they find out, why didn't you tell me about this? I mean, it's not a conversation that any clinician relishes, but you have to have it. And I mean, these are the times when the parents get an uproar, and then they write their congressman, and they go to the press, and things happen. But yeah, it's not a discussion that I like to have.
So earlier on, you had a quote about our system being faulty, and that's kind of the way to change it. So I don't know how much you ascribe to that idea, but do you think that with a solution you present, by other people that present solutions in the system, we kind of help keep the system going the way it is and staying away from changing the entire system because we keep trying to find these kind of very micromanaging ways of fixing the issues as they come about?
So if let me make sure I understood you correctly. Rather than kind of piecemeal and put a Band-Aid approach, what we need to do is trash the whole thing and come up with a new one, and since we're not doing that, are we kind of just perpetuating, is that correct?
Yes.
Fortunately, I'm not a politician, and I'm not a policymaker. I don't see, honestly, based on the stakeholders who are involved and what the considerations they have, that we're going to be able to totally rework the system. I think that the basic system is flawed, and I do think that the only way, at least in the immediate term, is to put Band-Aids on. I have a hard time seeing, even with the Affordable Care Act, within the United States, I have a hard time thinking that we're going to have a nationalized or socialized system where a lot of these problems don't happen. I just don't think it's going to work like that here. And I may be wrong, and I grew up in Israel, I went to medical school there. It was a very different healthcare system, by no means a good one. But I remember when I started looking at this, I contacted some physicians in Israel, and I was talking to them, and what shortages are you guys experiencing? And I won't tell you the choice Hebrew words I got, but it was like, what are you talking about? I mean, you guys are nuts. This doesn't happen. And I don't see how we're gonna, I don't know if there's somebody here who's more attuned to the larger U.S. healthcare system, but I have a hard time believing that we're gonna be able to totally work it.
But in your ideal, that would be.
Oh, in my ideal, I'd also be a professional tennis player. I mean, sure, I have pipe dreams. I think that the system has to be changed, but that's glacial. And I think that in the interim, we have to make some changes that are more palatable to the people who make those decisions. No question. But yeah, ideally, I would be playing Roger Federer in Australia right now, and we would have a better healthcare system in the U.S.
The other point to make, though, I think, is that this is not all malfeasance. This is not all drug companies just trying to make a buck. I mean, there are legitimately times when things happen, production of things. So I think some of the solutions are appropriate, given that stuff happens. It doesn't have to do with necessarily some major, someone out there trying to sort of grab as much money as they can. There's no question that there's a component of that that's driving some of this, but there are times when bad things happen and the production line goes down, and I think there is some thought that there are strategies within the existing systems.
Yeah, thank you, Ken. And it's not that there's a conspiracy. Remember, this is one of the reasons. And I chose also, remember, I'm a savvy test taker. I'm also hopefully savvy enough of a speaker. I needed to get you guys interested in this, so I'm going to pick on areas that are well-researched and well-defined, but maybe are a little bit more controversial, right? That's what we're doing, so. Yes?
But don't you think in a system that's as sophisticated as ours, that if we know that we have relatively simple to manufacture, inexpensive drugs that are life-saving, that we would never run into a shortage because we would appropriately stockpile those drugs. The drug companies should be doing that. I mean, one of the big drug companies has 3 very expensive drugs that are supplied to cancer patients. They work. And they have decided to take them out of the regular distribution system and distribute them through specialty pharmacies only. That costs us more to buy them. We have to pass that cost on to the patients and insurance companies. And when I said to them in a meeting, if you do this, does this guarantee that you will never have a shortage of these drugs in the U.S.? And they said no. So I don't understand why the system doesn't work that way. When you know these are life-saving drugs, why isn't there a stockpile that would always avoid having this kind of a shortage?
So the answer to your question is yes, I agree with you, and I don't know why. I can't tell you that, the people who argue it's a stockpile, there's expiration dates, this, that, the other, but when the auto industry was failing, when the mortgage companies were failing, the government stepped in and did something. They didn't want those to fail. And now you're getting my bias. When bald little kids with cancer don't have the drugs that they need to live, and they don't vote, and there's only 13,500 of these kids each year in the United States, the government didn't step in to take over. And maybe we need to have, we need to have a different system in place, right? I agree with you wholeheartedly. And I mean, the hepatitis C drugs. So for example, that $300 to $600 billion uptake, the Gilead, the maker of that company, has now contracted with CVS and some other specialty home pharmacy or pharmacists, and they're still going to make a lot of money. But they've done it in a way that, and again, what Ken said was true. I'm not trying to pick on the drug manufacturers. They're one of the problems, but this is very, very complicated with a lot of stakeholders involved.
It looks like we could go on for a while on this topic, but I want to thank Yoram for a really fabulous seminar today. And thank you all for listening.